My talk today will be on exercise among adults with pre-diabetes and type 2 diabetes, barriers and solutions. I don't think it's a very interesting topic for us as doctors because we know patient need to do exercises and we know the barriers as well. But my take on this topic will be entirely different within the 10 minutes I have. We know the prevalence of diabetes is around 10%, which is the tip of the iceberg. We know the prevalence of pre-diabetes is around 10 to 20%, which is again the tip of the iceberg. So that means when we point fingers at our patients, the people sitting in this hall, at least 1 in 10 is diabetic, at least 1 or 2 out of 10 is pre-diabetic. How many of us do regular exercises? Okay, that's a quite good number. Nice. But second thing, this is what we are really bad at. Sitting is the new smoking. So we spend 45 minutes of our day early morning walking, running, jumping, gymming, cricketing, playing football, but the whole day we are smoking. So kind of like it's like we leave drinking for or smoking for 5 to 6 months, and in 1 month we are again drinking the whole amount for 6 months. So just a 45 minutes exercise in the early morning and sitting throughout the day, is it the right way to go about it? That's a $1,000,000 question I have to ask this audience. So yes, with that at outset, there are certain barriers, there are certain physiological barriers. We know, see, the basic concept or the basic problem without any medical term is laziness. So how lazy you are as a doctor or how lazy you are as a patient is the right question. Everyone wants to do exercise, everyone wants to be in shape, nobody wants to be unhealthy. But problem is that even if the motivation level is there, how often we can practice it in our day-to-day life, and why is it happening? Imagine us being non-diabetic, no pre-diabetes at all, but still we feel it's quite kind of difficult to get up every single day, early morning, go for a walk, do an exercise. Imagine that exact same feeling double or thrice in a patient living with or a person living with diabetes. Because first of all, there will be reduced cardiorespiratory fitness. It's proven for person living with diabetes. Greater perceived exertion, like if we walk, the perceived exertion is much greater in again a person living with diabetes. Psychological barriers to exercise, motivation and self-efficacy, they always question. They don't have, it's not like they don't want to, but they always feel. It's kind of like a psychological feeling, it's too boring. And the negative past experiences and the embarrassment, usually they have, because sometimes how much ever they exercise, the blood glucose is not coming down, they just feel like giving up. Mental health, the increased prevalence of mental health disorders is not a secret. They have depression, they have anxiety, and we know that the people who live with depression and anxiety tend to exercise less, and that's again a quite important problem for us to solve. Now we have social and cultural barriers. This is what I want to again concentrate upon. Women with diabetes experience social and cultural barriers to exercise. It's a common phenomenon. Not only it's there in rural areas, urban areas I won't say. It's there. The lack of social support, childcare, and domestic responsibilities, putting others before oneself, maintaining the cultural and religious standards, lack of safety and vulnerability. Environmental barriers, the neighborhood deprivation, lack of resources in an area, influencing socio-economic status and the social determinants of health. Again, climate change, we know the air pollution is directly linked with diabetes. Again, extreme temperature deter us from going for an activity outside and go for a physical activity. If it's too cold, if it's too hot, if it's raining, we find many other excuses not to exercise at all. But before moving towards solutions, I will say there is something called what we say is built environment. Built environment is basically where we are living, whether do we have a right surrounding to do all the necessary physical activities. I'll just say my own example because I have 5 more minutes to go. I used to live in an apartment where there is no provision to go for a walk, because right next to my apartment is a busy road, and it was very unsettling for me, thinking that yes, I am unable to maintain my fitness levels. So I literally moved to a villa complex where there are 10 villas. I went for the villa, like before buying the villa, I went there myself, saw there is a swimming pool, there is a nice environment to walk, there is a ground, there is a gym, every facility is there. I have been staying there for last 2 years. I have never went to the swimming pool. I took the villa thinking that I'm going to exercise. So the built environment is not the only problem. We have to have the peer, not pressure, I would say. The peers have to be there. The family support has to be there. The mental support from the others. And one controversial thing about controversial news recently came up in Kerala. I'm from the northern part of Kerala, where a group of people started exercising together. It's called MEC 7, basically developed by a post major in army. He developed a group of set of 7 exercises which can be done in a done by a group of people, which is actually working. Many of my patients are coming back with wonderful results. The controversy is entirely a different issue. But what I learned from that is, if you go for a walk continuously alone is not going to go good in long term. But when we have a group, when we have a peer group with similar interests, similar problems, and that is going to go a long way. So one problem with me now, actually literally from January onwards, I'm going for my regular exercises. One important thing that happened in my built environment was that I have people doing exercises around me, surrounding me. They're not doing the same exercise. One is going to the gym, one is in the swimming pool, one is making the rounds, one is playing football there. I am the one alone doing some other exercise in the corner. But I know every one of them comes at the same time. We all exercise things differently, but thing is that at least they are there. So that makes me go, the little motivation is there. So making a group might actually help. So we know the barriers, now moving towards the solutions. Improving cardiorespiratory fitness through exercise training and medications, use of technology and self-regulatory behavior, the role of physicians and healthcare teams, and then folk behavior model of motivation, prompting, and ability, continuous glucose monitoring, pet ownership, socially and culturally competent interventions, and designing built environments. More less than or not, I would like to say one more important thing, which was mentioned by one of the previous speakers. When we prescribe diabetes medications, we don't prescribe like before, right? Patient has diabetes, lifestyle medication, metformin, then move on to the other drugs. It has changed over a period of time. We have guidelines saying that if the patient is having this, start this first, SGLT2 first, GLP-1RA, all those things, heart failure, CKD, everything is there. And why do we think that exercise is also a one-size-fits-all approach? You cannot just say the patient that you do exercise and come back. It's not definitely working, because none of our patients seems to be doing exercises for long term. So why don't we see the patient as a whole, whether he or she is an elderly, they have a knee problem, how much flexibility do they have, what kind of exercise that can be prescribed. So the trend of appointing a nutritionist in a diabetes clinic has been there in the last decade or so. Why don't we have a fitness coach also who can give individualized exercise prescriptions according to the patient's age, preference, any other comorbidities present, and so and so. So that will be my most important solution for all the problems. You can have all the CGMs in the world, you can have all the like smartwatches counting your steps, everything, because there are a lot of RCTs which I went through. Many of the RCTs for exercise group and the control group, at 8 weeks the study group showed really good results, but in long term the differences tend to wean off. So that is actually a problem. It doesn't mean that if we keep on saying them do exercise, or if we keep on supporting them in terms of messages or something, it's not going to work like before. So we need a fitness coach or fitness expert, or someone just like a nutritionist in our clinic. So this is the nutshell of my today's talk, the exercise barriers and solutions. And conclude, people with type 2 diabetes exercise less than the general population. We need to explore traditional and novel barriers to exercise in those with type 2 diabetes, and potential unique evidence-based solutions to overcome these barriers include self-regulatory behavior strategies utilizing wearable fitness trackers, CGMs, a real-time feedback tool, and promoting thoughtfully built environment to increase green space for physical activity. Thank you.